Okay, everyone, settle down, settle down. So today we're tackling a massive topic, one you'll be dealing with for your entire career. The question is simple, but the answer is complex. When the heart, our body's most important pump, starts to fail, what do? We're going to look at the whole story, from the old school drugs to the modern strategies that are saving lives today. Cello, let's begin.
First things first, let's get one thing straight. Heart failure is not like what you see in the movies. It's not a sudden dramatic event like a heart attack. Not at all. It's a progressive disease. That means it slowly gets worse over time, a gradual decline in the heart's ability to do its job. Our goal as doctors is to understand this decline and, more importantly, to know how and when to step in.
So here you have the proper textbook definition, but let's break it down into simple terms. Think of the body as a huge, bustling city. The heart is the central power station. Now in heart failure, that power station either can't generate enough power to keep the city running, or it can only do so by running at a dangerously high level, risking a complete blackout. It's a fundamental crisis of supply and demand. Simple as that.
Now this failure can happen in two main ways. First, you have a pumping problem. We call this systolic dysfunction. The heart muscle is just too weak. It can't squeeze hard enough to push the blood out. But then you can also have a filling problem. That's diastolic dysfunction. Here, the heart muscle is too thick and stiff, so it can't relax properly to fill up with blood. Two different problems, but they lead to the same terrible result. The body is starved of the oxygen it needs to survive.
Okay, so how did we treat this in the old days? Well, for many, many years, there was one king of heart failure drugs, and that was digoxin. It was the go-to, the old workhorse that every doctor relied on.
This graph here really shows you the magic of what digoxin could do. See that blue line at the bottom? That's our failing heart, really struggling to pump. The red line way up top, that's a normal, healthy heart. Now look at the green lines. That's the digoxin effect. It literally lifts the performance of the failing heart, pushing it closer to normal. How? It increases the force of every single contraction. We call this positive inotropy. Basically, it's like giving the tired, weak heart muscle a powerful shot of adrenaline.
But, and believe me, this is a very, very big but, this powerful drug has a really dark side. It is a classic double-edged sword. While it can be a lifesaver, it's also incredibly toxic if you are not extremely careful. This is what we call the danger zone.
And this number you see here, this is exactly why digoxin is so tricky. The therapeutic index is the window between a dose that helps and a dose that harms. For most drugs, that window is quite wide. For digoxin, it's tiny. It is dangerously narrow. It's like walking a tightrope with no safety net. And because this drug builds up in the body, that tightrope gets even more precarious with every dose.
So it is absolutely crucial for you to spot the signs of toxicity early. And here's the thing, the first clues are often not heart-related. Your patient won't be complaining of chest pain. They'll complain of things like having no appetite, feeling nauseous, vomiting, being confused, or even seeing things strangely, like a yellow or green tint to everything. These are your early warning signs. You must be on the lookout for these on your rounds. Because if you miss those early, subtle signs, the problem goes straight to the heart. And that is a code red emergency. Seriously. Digoxin can cause basically every type of arrhythmia you can imagine. We're talking irregular rhythms, life-threatening ventricular tachycardia, a complete shutdown of the heart's electrical system. This is a true medical crisis.
And when that crisis hits, you have to move fast. Step one, obviously, is to stop the drug immediately. Then, you treat the specific problem. You might need to give potassium, because low potassium makes the toxicity much, much worse. You might use lidocaine for the dangerous arrhythmias, or atropine if the heart rate has dropped to a critical level. This is the emergency protocol you need to know.
So, because of these dangers, and also because we started to understand heart failure in a much deeper way, there was a total revolution in how we treat it. We figured out that just whipping a tired horse to run faster wasn't the solution. The real breakthrough was realizing we had to break the vicious cycle that was driving the disease itself.
And this is the great, cruel paradox of heart failure. When the heart gets weak, the body thinks it's helping. It goes into panic mode. It releases all these hormones to increase blood pressure and hold on to fluid, trying to compensate for the weak pump. But in reality, these so-called compensatory mechanisms are actually a death sentence. They force the already failing heart to work against even more pressure, causing more damage and creating a downward spiral.
Okay, look closely at this diagram. I know it looks a bit complex, but it tells a very important story. It all starts up here, with reduced cardiac output. This triggers the body's panic response. The renin-angiotensin system, or RAS, and the sympathetic nervous system go into overdrive. This whole cascade just makes the heart work harder and harder, which causes even more damage to the heart muscle, which leads to even lower cardiac output, and round we go in a vicious cycle. But here's the brilliant part. The modern breakthrough. We now have drugs that can intervene. Look, ACE inhibitors, they block the RAS right here. And beta blockers, they block the sympathetic overstimulation here. We can actually break the cycle. We can stop this self-destructive process.
So with this new understanding, we've developed a completely new strategy, a modern treatment blueprint. We don't just throw one drug at the problem anymore. No, we stage the battle. We use different weapons at different stages of the disease.
This chart, this is your game plan. This is the modern, step-by-step guide to managing heart failure. Look at the bottom. Even for patients who have a weak ventricle but no symptoms, we start them on an ACE inhibitor or an ARB. As the disease gets worse, moving to mild and then moderate stages, we add in beta blockers and diuretics. For the really severe cases, we might add drugs like spironolactone, and only then, way down the line, do we even consider digoxin. It's a logical, evidence-based progression. So this is our modern toolkit, our arsenal. ACE inhibitors are the foundation, what we call the sheet anchor of therapy. Beta blockers are the shield, protecting the heart from the constant barrage of stress hormones. Diuretics are for symptom relief. They put out the fire of fluid overload and congestion. And aldosterone antagonists, well, they help prevent the long-term structural damage to the heart muscle itself.
This quote really sums up the whole revolution, doesn't it? We went from just treating the symptoms, just putting a Band-Aid on the problem, to actually targeting the deep underlying cause of the disease. We're not just managing failure anymore. We are fighting the neurohumoral perpetrators that cause it. It's a total paradigm shift.
We have come such a long way in this fight against heart failure. It's truly incredible. But the war isn't over. And the next great frontier, the challenge for your generation of doctors, is this. Can we go beyond just stopping the damage? Can we actually reverse it? Can we one day find a way to truly heal a broken heart? That's the question I leave you with.